and welcome back to our Emergency Medicine Academy podcast. This is me, Hassan Abdurrahman, one of the co-founders, and with me, my colleague and my friend.
Hi, Muhammad Fagir. I'm one of the other co-founders and instructors of Emergency Medicine Academy.
Welcome back, and we're going to talk about very important topic today, which is Mental Capacity Act and how to assess the mental capacity for patients presenting or visiting the hospital, either emergency department or in any parts of the hospital. And we're also going to talk about the Mental Health Act. So it is a very important topic, and I think we as a healthcare providers, at some point, we face the mental capacity assessment for the patients, particularly when we came to the sharing plan and sharing management plan with patients or specific treatments. And we face that those patients are refusing to get specific or certain medical treatment. And we came to the point that we need to do the mental capacity assessment. It is a very important topic, and I think we should have an idea and knowledge about how to deal with these patients. So without further ado, let's start. Muhammad, so I'm just going to ask you what is mental capacity so people can have an idea about the meaning of that.
All right. So mental capacity basically is the ability of someone to make decision about their medical care at the times when it needs to be done.
Right. So it is matter of ability of the patient to have an idea and or to make a decision about the certain provided medical treatment. So and what is the exact definition for the mental capacity?
Yeah. So according to the Mental Capacity Act, it's a legal framework to empower and protect vulnerable people to make decisions about their medical care when they lack capacity.
All right. And I think there are several principles which we need to keep them in our mind when we are dealing with capacity assessment for patients. And I think those principles are quite important, and they just like give us an idea about the general approach and general information about the mental capacity.
Yeah. I mean, the principles of mental capacity, I think they are really important to understand and to keep them in the back of our mind at all times when we deal with mental capacity in the emergency department. Yeah.
Correct. So I think they are total of 5 principles which we should have an idea and understanding about them before doing the mental capacity assessment. So let's start by the first principles of the Mental Capacity Act. So the first principle that person should be assumed to have capacity unless it is established that they lack capacity.
Yeah. So presumption of capacity, and this is really important. So we cannot assume that someone is lacking capacity just because they present it with any condition. For example, like if they have mental health problem, or if they are intoxicated, like heavily intoxicated, or if they have any, for example, head injury or low GCS. So we cannot assume someone is lacking capacity until proven otherwise. And we should assume that everyone is having capacity first until we do our assessment.
Yes, I think this is quite important because I've noticed several times, or just like from my general understanding, that sometimes doctors or healthcare provider, they're just seeing intoxicated one attending the hospital, and they make an early assumption that this patient is is going to lack capacity because of their presentation or because of their intoxication. So we need to assume that everyone is got a capacity until proven otherwise. So principle number 2, this a person should not be treated as lacking capacity unless all practical steps have been tried to enable capacity.
Yeah. So we should support our patients to make their own decision. And this is another important thing to consider. We can't just say, if someone is like refusing treatment, okay, this is your right, you have capacity, before we really support them. How to support? So there is a lot of measures we can take, actually, so to support them. For example, I'm going to provide them with detailed explanation about their medical condition and about the benefits if they accepted to have the interventions we are planning for them. And also we need to let them know about, the downsides and the risks which might happen if they refused our treatment or the management plan. Okay? For example, let's say if someone is coming with chest pain and I'm concerning about possibility of ACS, for example. So I should first explain to them the condition, what I'm concerning about, what are the benefits if they accepted to have the treatment, to see the cardiology. They might need, to have cardiology interventions for that. And if they refused, what are the possible potential consequences? For example, their condition is likely is going to deteriorate, and even their heart might stop and they might die if they refused. So we should explain in details what are the risks and benefits for particular treatment. If you are going to give any medicine as well, for example, like if you are going to give thrombolytic for someone suspected to have like massive PE, for example, then we should explain to them what are the benefits, what are the risks as well. Okay? So this is the first step on supporting our patients to make their own decision. And if there is any alternatives as well, so we need to let them know about. For example, if they are refusing to have IV medication and there is alternative like oral ones, so we need to make them aware about it as well. Okay? So this is one of the steps. The other thing, we need to address their concerns. So check with them if they are refusing to stay, for example, like, why are you refusing to stay? And sometimes it could be something simple. For example, they have an appointment somewhere else, so we can see if we can help, if they would like. Sometimes they might just be quite hungry because they have been here for a long time. Then we need to probably provide them with some tea and coffee or a sandwich. That might be all needed to convince them to change their mind and stay. If they are concerning about your treatment, then again, we should listen to them and address and explain more. Okay? Another thing to consider is to involve significant others. Significant others from the patient side and from our side as well. From the patient side, we could involve, after their consent, of course, we could involve their next of kin. We could involve their loved ones, so they might succeed in convincing them to have that particular intervention. From our side, we might consider involving another colleague, senior colleague. We might consider involving the nurse in charge. They are really excellent and helpful in this issue, and they might convince them to actually accept. But also we can involve the medical team, and also we can involve the mental health team as well.
So they can support for the patient to make their own decision. I think you mentioned very vital information here. And I think because we need to communicate, so you mentioned a very important point here, which is we need to explain to the patient the risk of leaving the department or the risk of not receiving that particular treatment. And this is quietly affecting their way of thinking, and they might just change their mind. For example, the same example which you mentioned, that patient coming with ACS, they might just like say that I don't want to have any further intervention or any further treatment. But if we're going to explain to them the risk proposed, that they might got this complication and that complication, at that time they might just like step back and rethink again about the condition, which is very important. And I think sharing the information with the patient and giving them more details about their condition, this is also building a good rapport and communication with the patient. And this is eventually going to help them making the decision needed for their treatment. Brilliant. Sometimes we are facing that the patient is making unwise decision, and this is for us as healthcare providers. If the patient refusing, for example, thrombolytics or refusing to go to cath lab, and we are thinking that this is unwise because we are in the medical field and we know what consequences can happen as a result of that. So their decision is sounding unwise for us. So this, I think, brings us to the third component of the Mental Capacity Act, which is a person is allowed to make an unwise decision. What do you think about this principle?
Yeah, so this is the third principle of mental capacity. As you mentioned, people have the right to make what sounds like unwise decision. Saying that if someone, for example, is making what sounds like unwise decision, that doesn't give us, the right to consider they lack capacity just because of this. But actually, after explaining to them everything related, as we mentioned earlier, they have the right, and if still they are insisting to refuse your intervention or your treatment, despite explaining everything, and they deem to you to have full mental capacity, then we should respect that. We cannot force someone to have treatment just because their refusal is sounding unwise.
Yeah. So I think if it sounds unwise for us, that's we should respect this, and we shouldn't argue regarding that, despite though it sounds unwise for us. Yeah.
Exactly.
If a person lacks capacity, then the decision should be made on their best interest. So this is a principle number 4.
Yeah. So the fourth principle, which is when someone is lacking capacity, we should treat them on their best interest. And that's really important. So the best interest decision, it depends on the particular circumstances, particular patient, and it's largely affected by what we think from medical point of view, what's appropriate to them, but also we should consider what's important to our patients, what are their values. So it's a combination of things we should consider before managing the patient. At the end of the day, it should be the best, as we believe, for our particular patient.
Right. And I think at the end, when this the patient regain capacity after the treatment has been already initiated or started, we should explain to them what's happened, and that we assessed them at that time, and there was lacking capacity. So we proceeded to treat them on their best interest.
Yeah.
Let's jump to the last principle of the Mental Capacity Act, which is any decision made should be the least restrictive in options.
Yeah. So if we concluded that someone is lacking capacity for a particular decision at particular time, and actually we need to apply some sort of restraint if it's really necessary, then that should be the least restrictive. We don't need to do, too much restraint unnecessarily. For example, if the patient is quite agitated and actually they are posing risk to themselves or to others, then we need to start with, try verbal de-escalation. And then if that's not working, we might consider chemical sedation, okay? And then if this is not working, it depends on the situation itself and the urgency, actually, okay? But in general, we need to choose the least restrictive option. I can give you an example of this.
Yeah.
For example, if you have an elderly patient who's, for example, he's coming septic and he's quite confused and agitated and shouting, refusing to have the blood tests and the IV antibiotics. And after, addressing their mental capacity, if we concluded that they lack mental capacity for this decision to have this blood test and antibiotic at this time, then, and we couldn't manage to verbally convince them, then we could consider using probably like a light sedative, okay, just to calm them a little bit down, as long as that's safe, so we can proceed and get the IV line and the cultures and antibiotics and everything.
Right. So the least restriction will be just like to provide the medical treatment or the plan for the patient just on that. So we shouldn't make any harm for the patient. So just like very brief and very least restriction until the proposed medical treatment being provided, and that's it.
Exactly.
Right. Good. So now we can go and we can have a chat about the assessing capacity itself. So what are the components of the mental capacity assessment? I think there is 2 stages for mental capacity assessment. Can you just enlighten us about those 2 stages of the mental capacity assessment?
Yeah. So actually we have the 2-stage mental capacity assessment. And that means the first thing is there any, that's the first question, is there any condition that's causing impairment to mind or to brain? For example, if someone is coming with who's known to have mental health problem, okay, like severe intoxication, head injury, for example, severe dementia, sepsis. Sometimes people might come with electrolyte disturbance, hypoglycemia, hyponatremia, for example, head injury, intracranial bleeding, stroke. So a variety of presentations, okay, which might let us think the patient might have impairment of mind or brain. So if that's the situation, then do they have full mental capacity to decide or not? And that's and here it comes to the assessment of mental capacity. So in terms of assessment, we need to assess if they understand the information we provide, and then if they can retain these informations, and then number 3, are they able to weigh up the pros and cons of their decision, and lastly, are they able to communicate their decision by any means?
Right. Very good. So there are 4 steps for the assessing patient capacity. So first of all, we need to make sure that they understand the decision to be made. And I think for them, to have a full understanding, we need to explain to them fully about what's going on now and what's the proposed diagnosis which we are working for, and what are the decisions need to be made for them to have a proper treatment, and what are the complications which might happen. So we need to give them full information, as you stated at the beginning.
Yeah.
So this will help them have a better understanding about the general picture. And then we ask them to, or just like we offer them to retain the information sufficient long to make the proper decision.
Yeah. So sorry for interruption,
Yeah.
but we need to check if they can retain the information. So after explaining all of that, from the beginning, I will tell the patient, I'm going to tell you some information regarding this problem, for example, okay? And then I'm going to ask you to repeat that back to me. So first of all, I will provide all the information. What are the, the consequences if they accepted, if they refused, what are the possible complications. And then I will ask them to repeat back to me what I have just told them. This is to assess if they can retain the information.
So by repetition, we can come to the conclusion that patient in front of us is able to retain the information long enough. That's good. Yeah.
And then we will think about if they are able to weigh the pros and cons of their decision. And if you notice, this is a bit tricky because this is subjective, because that's your understanding, okay? And actually, mental capacity assessment at best is an opinion. So sometimes I might assess someone's capacity and I conclude that they have mental capacity, but you might come and say, actually for you, you don't think they have capacity. And someone else might conclude that they actually have capacity. So mental capacity assessment at best is an opinion.
Correct. Yeah. And the last component is the ability for them to communicate their decision.
Yeah. So, and it's not necessary for the communication to be verbal. So by any means. So they might use, probably writing down and tell you what they prefer, or they might actually use like sign language. So by any means, communicating their decision by any means.
So it can be implicit or written. So by any means, just like to have an idea that they are able to communicate their decision. I think there is a very important point it is worth to mention in here. For example, if we face a person who is refusing a certain treatment or management provided from us as a healthcare provider, just before jumping to assess the capacity in general for this patient, we can try our best just to convince them to have the treatment before jumping to assessing the capacity. What do you think about that?
100% I agree with you. Before asking the patient or going and assess their mental capacity, usually I sit with them, and this falls under, if we go back to the principles of mental capacity, that we should support patients to make their own decision. So it's really important to sit with them and address their concerns and try to convince them to accept our medical opinion, because I think most of the time this helps and it works well, really. It's just like if we sit with them, we show that we are good listeners, we are showing empathy and sympathy. I think that's all, most of the time that's all needed, to convince our patients to accept our plans for them. And the other thing which I would like to highlight, mental capacity assessment is time-specific, decision-specific. So we might assess mental capacity for someone now, and they might be deemed to us to be lacking capacity, but after 10 minutes, they might actually regain it. So it's not like someone, he lacks capacity for everything during his stay, but it's time specific. and also it's decision specific. So capacity assessment for example, to have investigations or to have particular treatment. And sometimes people might actually have capacity to consent for having these particular investigations, but they might be, lacking capacity for deciding to stay or leave. All right. So it's time specific and decision specific.
Yeah, I think this is very, very, very important. And I think capacity can be assessed, as you mentioned, several times. We can assess it now and then after 10 minutes, 15 minutes, 1 hour, and later on, and things might change.
Exactly.
With this frequent assessment. I think a good example for this, if we got a patient who came septic and with peritonitis requiring operation. And initially, when we assessed the capacity of the patient, we found that patient was lacking capacity. But after initiation of the initial treatment in the A&E, for example, giving the patient fluids and antipyretics and analgesics, and patient improved, and then we assessed the patient capacity again. So initially he was refusing to have an operation, but then after initiation of the initial treatment, he responded well, and now he got the capacity and he might agree for the operation. So we need to do the assessment frequently, and this is, I think, it will have a very huge impact.
Yeah, it's dynamic.
It is dynamic and it is changing frequently. Brilliant. So now we want to talk about the Mental Health Act sections. I think in UK there are several sections for the Mental Health Act. So let's start with, so there are too many. So we have section 2, we have section 3, we have section 5 to 136 and 135, and we have section 17. We're going to highlight them as we are digressing through. So let's start with section 2. So can you talk to us through section 2 and give us more details about it?
Yeah, sure. So before talking to section 2, if you allow me, I would like just to mention that it's really important to have basic understanding of Mental Health Act. I think we are, as emergency medicine practitioners, it's really important for us to have this knowledge about Mental Health Act and mental health assessment that will make sure our patients will be safe, and also it will facilitate the communication with the liaison psychiatry and mental health teams. So this is really important. We're not going to talk about all Mental Health Act sections, but we're going to touch some of them. And regarding section 2, so first of all, who can approve or apply section 2? So I am, as emergency medicine practitioner, I don't have the right to put someone under section 2 of the Mental Health Act or section 3, for example. So it needs to have 2 approved mental health practitioners, and one of them must be section 12 approved. Section 12 approved, that means they have taken section 12 approval course, okay? And that will say that they have the experience and knowledge to manage mental health problems. So section 2 and section 3 can only be applied by mental health team, okay, or by 2 approved mental health practitioners, and one of them must be section 12 approved. Section 2 allow for detention, and detention means keeping someone by force for up to 28 days, and it's for assessment of their mental health. So it's mental health assessment for up to 28 days. Okay?
Right. Good. And so it is for the assessment. So section 2, is there any chance that we can provide certain treatment, or it is just only for pure assessment?
That's a good question. So it's basically for mental health assessment, but sometimes could be used to treat mental health problems. For example, mental health team can use Section 2 to provide mental health treatment as well, if really important and urgent. But basically, it's assessment. You might ask, can we treat medical problems using Section 2? So basically, if someone is having medical problem and if they lack capacity, then we can treat them on their best interest, as we said earlier. But if the patient is sounding to have full mental capacity and they are under Section 2, then basically we don't have the right to treat their medical problems using Section 2 unless the problem is directly related to their mental health problem that they presented with. Let me give you some examples. For example, someone is coming with laceration and they got that laceration like self-harm because of the mental health crisis they are having at the moment, then we might be able, after liaising with the mental health team, to manage this wound using Section 2 of the Mental Health Act. But that needs to be discussed with the mental health team first. Okay? So the medical problem should be a direct consequence of the mental health issue that they presented with. Another example, like if someone is known to have anorexia nervosa and they presented with severe dehydration, which is directly caused by their mental health problem, then also we might be able to give them some IV fluid by using Section 2 of the Mental Health Act, which is applied by the mental health team. But for example, if someone is presented with paracetamol overdose and now they are requiring antidote, then this is more of medical problem, even though they have taken the paracetamol because of their mental health issue, then we might not have the right to manage the overdose using Section 2 if they have full mental capacity and they are refusing your treatment. So it's a bit tricky and it needs a senior discussion and it needs discussion with the mental health team as well.
Yeah, I think it is worse, just like if you face this condition and you are in the gray zone and you cannot make a decision, to ask seniors or just like to ask the mental health team as well so they can support with that. But it is mainly for detention for 28 days for general assessment. Yeah,
mental health assessment.
Mental health assessment. So let's talk about Section 3.
Yeah. So Section 3 of the Mental Health Act, as I said earlier, it could be applied only by 2 approved mental health practitioners. One of them is Section 12 approved. So we, as emergency medicine doctors, we don't have the right to put someone under Section 3. Okay? And Section 3 is for treatment of mental health problems, and it's for 6 months. So the patient could be detained for 6 months, and that actually could be extended for additional 6 months.
Okay, so Section 3 is for 6 months and can be extended furtherly for 6 months if required.
Yeah, and usually the patient will be admitted to a mental health facility.
Brilliant. And Section 5.2.
Yeah, so Section 5.2, it's not applicable in the emergency department. It's only applicable in the inpatient wards. So this is doctor approved. So any doctor can apply it as long as they are registered in the relevant registration bodies. And actually, it lasts for 72 hours. So let me give you an example to explain it more. A patient in the medical ward suddenly became agitated and posing risk to themselves or to others. So the admitting team, the doctor, could put them temporarily under Section 5.2, and they can manage their aggression and provide any life-saving management, okay, using Section 5.2.
Good. And now we can go to Section 136.
All right. So Section 136, this is only applied by police. And this is where the police is bringing or removing someone from public place if they are sounding to have mental health problems and the police believe they might pose risk to themselves or to others. So it's only applicable in public places. And usually police will remove that person to a place of safety to have mental health assessment. ED is one of the places where it's considered place of safety, but also they might take them directly to a mental health facility, and sometimes they take them to like a police station, but that's not common. So most of the time they come to ED accompanied by police, and they are under Section 136. So those people, they need mental health assessment. However, they might need assessment by our side as well as emergency medicine team, because they might have physical problem as well, or they might have physical problem which might causing their presentation. So they might need dual assessment between ED and liaison psychiatry.
Yeah, I think,
but not all times. Sometimes they might be only for mental health assessment.
Yes. I think we are facing this frequently, that patients are brought in by police. Yes, sometimes we are seeing them in the ED because of the physical problem, and after we finishing our assessment from ED point of view, we are just sending them to have an assessment by psychiatric team. Is there any chance that they are sometimes bringing this patient under 136 section just for pure physical assessment without psychiatric assessment?
No. So they might present for only mental health assessment, but usually if there is no mental health issues, then the police will not put the patient under Section 136, because 136 means suspected to have mental health problem affecting their mind and posing risk to themselves and or to others. But frequently they need dual assessment by us as well. I mean, for those people in general who presented with police, accompanied by police to the emergency department, we should ask police if they are, because there is only 3 situations where people will be accompanied by police. If they are only escorting them, that's the first thing, or if the patient is under arrest by police, or if they are under Section 136. So every single time we need to clarify with police under which grounds they are accompanying the patient. Okay? Regarding 136, it lasts only for 24 hours, but could be extended by additional 12 hours up to 36 hours.
Right. And while we are talking about those patients brought in by police, I'm just going to ask a question, a bit not related in here, but yes, sometimes we need to do proper assessment and examination, and the patient is under handcuffs. So what do you think about that? Is it our decision to be taken if we need these handcuffs to be taken off?
Yeah, this is an important question, and frequently we might face that in the emergency department. So in general, we need to keep and respect patient privacy, okay? And we need to keep the restraint to the least possible. That's the general rule, and only to the period that there is risk. So not like for long periods. However, if someone accompanied by police and they are handcuffed and the patient is asking to remove the cuffs before giving you any information, then I would talk to police first and ask them if they think it's safe to remove the handcuffs. And if the police officers, if they believe this is not safe, then we must respect that, and we will keep the handcuffs. Okay?
Yes.
The other thing, if the patient is insisting that police leaves the room before they talk to you, because that's happening as well. So again, I'm going to have a chat with the police officers and ask, do you think it's safe that you can step out of this room and to let me have a conversation with the patient? And if they believe that's not safe, then I would accept what the police are asking, or they are their opinion, and they can or they should stay inside the room as well.
Brilliant. And so if we need to do an intimate examination and we ask the police if it is safe for us just like to do this examination or intimate examination in their absence, and they mention that they cannot leave the room. So I think it is to maintain the dignity for the patient, at least if they can stay in the room, if they think that it is safe for them to stay and safe for us as a doctor and for the police to be staying inside the room. It is just like to turn their faces to the wall, for example, to conduct the intimate examination, just like to have patient got dignity and respect.
Yeah, and of course, we are going to have chaperone as per the guidance from the Royal College of Emergency Medicine. So these examinations, there must be a chaperone with us. The chaperone should be one of our team, like a nurse or another doctor, okay? And yes, if the police, if they don't think it's safe to leave the room, then we will accept their presence.
Right.
Yeah. And also the patient is happy for us to proceed for the examination as well.
Good. Section 135 is also related to the police, I think, but there is a bit different in between 136 and 135. What are the different? What's 135 section stand for?
So the most commonly used is 136, where police, they have the right to remove someone from public place. Yeah?
Yes.
136 or 135, if the police, if they think that there is considerable risk to the patient and or to others from having like self-harm or harm to others, then they might enter the a private property and remove someone to where they can have mental health assessment. It's less frequently used than 136, but sometimes it might be applicable and urgently needed.
Right. Let's touch the last section, which is section 17.
Yeah. So section 17, this is when you have a patient who is admitted to a mental health facility, and actually they are transferred to your emergency department because they might have physical problem. So it's legally important for us to ask about if they have section 17 paperwork. So any patient coming from mental health facility to the emergency department, we need to make sure that there is section 17 paperwork. And actually it's called leave of absence. Okay? So that's like temporary, allowing the patient to leave the mental health facility for various reasons.
Right.
Yeah. If it's not accompanied, if we couldn't find that paperwork, it's really important to detect it.
So if they didn't have that paper, so we need to make a detect. So, but ideally, usually or generally, they are coming to the hospital for assessment, accompanied with this paper. Yeah. Muhammad, I want to ask you, if we got a patient who came to the emergency department with deliberate self-harm and suicidal intention. And we try to make a consent or to take a consent from the patient and to offer them to be seen by psychiatric team for assessment. And they are refusing. So what are the steps which can be taken in this condition?
That's an excellent question. So basically, if someone presented with deliberate self-harm and there is evidence of mental health problem, either from their past medical history or from our current assessment, then those people, they will require to be seen by the mental health team. So basically, I'm going to do my capacity assessment as usual and see whether they have full mental capacity to decide for themselves or if they lack mental capacity. Putting in mind that capacity assessment at best is an opinion, as we said earlier. So if I think the patient is having full mental capacity, then I will have a good communication with them to try to convince them to, that I'm going to manage their medical problem, but also they need dual mental health assessment to manage their mental health problem. And if they accept it, then there is no issues and they will have both, okay? Let's say that someone is lacking mental capacity. So you did your assessment and you concluded that they deemed you to lack mental capacity because of probably they are not understanding your information, or they are unable to retain the information, or if you think they are unable to weigh up the pros and cons of their decision or to communicate their decision, then we are going to treat them on their best interest. Yeah?
Yes.
But sometimes it could be a bit difficult because there is subjective element in the mental capacity assessment, which is if you think the patient is able to weigh up the pros and cons of their decision. And sometimes the patient might sound to have full mental capacity, but actually, for example, their mental health problem might be affecting their mind, and actually they might not be able to weigh up the pros and cons of their decision because of their mental health problem. Let me give you an example. If someone is known to have depression and they came with self-harm, so the depression they are having actually might be clouding their mind and impairing their ability to weigh the pros and cons of the decision they are going to have. So in such tricky situation, it's really important that we involve the mental health team as well. So those people, it's better to be assessed by different legislation as well, which is the Mental Health Act, rather than depending solely on Mental Capacity Act. So if they are sounding to have full mental capacity, but we are not sure whether they can weigh up the pros and cons of their decision, then it's better to involve the Mental Health Act as well, or the mental health team to assess them from their point of view. And sometimes they might come and conclude that they believe the patient is lacking capacity because they believe their mental health problem is affecting their mind and impairing their brain. And they might conclude that they are going to detain them, for example, under Section 2. Okay? Or most of the time, they might say, we are happy from mental health point of view, and we think from that point of view they are safe to leave. We are going to arrange some community mental health follow-up as well. In the situation where people insist to leave against medical advice, and from mental capacity point of view, our assessment deemed to have full mental capacity, we cannot force someone to have medical treatment as long as they are refusing to have it. But even if they are at very high risk of suicide and they are planning to leave, if there is immediate risk to harm themselves or others, then we might actually consider, keeping them by force. In particular, if we are considering that, their mental health problem is impairing their mind to take the right decision. So we might treat them on their best interest in that situation. But if they, we agree that they do have full mental capacity and they are insisting to leave and there is no immediate risk to life, then we should involve the mental health team, and or we could also contact their mental health crisis team in the community, contact their next of kin and their GB as well. This area is a bit gray and very difficult situation, so it needs decisions, and it needs to be escalated to the seniors. I would prefer my patients who come with mental health problems and self-harm to be seen during this visit by the mental health team as well. If any doubt, then we should escalate to the most senior and also in the department and also to the mental health team. And sometimes we might need to escalate to the legal team as well.
Yes, yeah. You give a very excellent explanation, particularly for this area, which is gray area, particularly if we assess the patient and the patient got capacity. And so sometimes we might need to escalate this to the mental health to ask for support. We can ask the senior doctors or other colleagues to come to help us. And if the patient got a capacity and they decide to leave, we shouldn't just make documentation in the notes that the patient got capacity and patient is free to leave. We need to do protective measurements and safety nettings by letting the community mental health team be aware about that. And as you mentioned, talk to the GP and involve the next of kin about the possible hazardous event which might happen because we discharge this patient. Yes, thank you very much for this explanation. Yeah, it's quite.
Another thing I want to add regarding documentation. So whenever we assess mental capacity for someone, we need to have that clearly documented in our notes. It's not enough to just document that patient is lacking mental capacity, but we need actually to document that we have assessed the mental capacity for this particular decision at this particular time, and actually they deemed to have full mental capacity or they deemed to lack mental capacity because of, and we need to document if they understood the information, they were able to retain the information, able to weigh up the pros and cons of their decision, and able to communicate. So clear documentation is a must.
Exactly right. So people just tend to use that patient got capacity, patient lack capacity. But I think in several hospitals now there is some project done in the writing notes for the patient. We have a format now for capacity assessment. So I think we strongly recommend to ask your hospital if they got any specific format for clear documentation so you can use that. And this is just following the details of capacity assessment. You just need to fill the information there and keep a clear documentation rather than just writing as patient lack capacity or patient got capacity. Now let's talk about lasting power of attorney, LPA. So can you tell us why we're using it for?
Yeah. So lasting power of attorney, this is when someone appoints another person to make decisions on their behalf regarding their care in the future when they might lack mental capacity. So the person who appoints another person, this is called the donor. And the one who's been appointed, this is called the attorney. Okay? There is two types of lasting power of attorney. There is LPA for health and welfare, and there is LPA for property and financial affairs. They are separate. All right? So we need to make sure that if the patient or someone saying that he's having lasting power of attorney for someone else, we need to make sure in the emergency department this is for health and welfare.
Right. So when the patient is planning for LPA, so at that time they should have a full capacity.
Exactly.
At the time.
Exactly.
And what about the age cutoff? Is there any cutoff age for which a person can decide to have an LPA?
Yeah, this is a good question. So the person who is appointing someone else to act as having lasting power of attorney, they must be over 18. So those who are 16 or 17 or children less than 16, they don't have the right to appoint someone to act as, having lasting power of attorney for them.
Right.
Yeah.
And the LPA usually for refusal of specific treatment rather than requesting a specific treatment.
So it's not like that, okay? Let's make some clarification. But before saying this, let me just mention that it must be registered with the Office of the Public Guardians, this document, okay, before it becomes valid, all right? Actually, when someone is appointed as having lasting power of attorney, for example, for health and welfare, so they can take decisions for the patient, all right? There is some situations where they can't make decisions by consenting or by refusal. And these particular situations, for example, if the patient himself, the donor, is having full mental capacity. So if you have a patient and he's having full mental capacity in front of you, then no other person can make decisions on their behalf, even if they have lasting power of attorney. Okay? The other thing, if the treating team, the medical team who are providing the treatment for the patient, if they believe that a particular intervention or treatment is not appropriate, then the person who's having lasting power of attorney, they can't demand to have that treatment. Of course, we are going to sit with them, have a discussion and conversation and everything, but at the end of the day, if the treating team believe this is inappropriate intervention for the patient who lacks capacity, then they don't have the right, those who are having lasting power of attorney, to insist, if that's your question.
Yes. And yes, that's my question. And I think just like I want to stress on this point because there is a bit of confusion when we are talking about the LPA. So we need to make sure that the patient lack capacity at that time. So if the patient got capacity at any point, so the LPA is not valid to be used.
Yeah, and there is another situation. Let's say someone appointed another person to have lasting power of attorney to decide on their behalf when they lack capacity in the future. And then after a period of time, and still the patient is having capacity, let's say they requested not to be resuscitated if their condition deteriorated in the future, and they completed and they have DNR form, for example. In this situation, when our patient lacks mental capacity, the person who's having lasting power of attorney, they can't override this decision, which has been made by the patient himself when he had capacity.
So the LPA will...
Does that make sense?
Yes, the LPA will be valid. So they don't have the right to change the decision made before.
So they can't change the decision made by the patient
Yes.
To refuse particular intervention
Yes.
just because they have lasting power of attorney.
Yes, so they cannot request a resuscitation, for example, for a person who already made a decision of not having a resuscitation.
Yeah.
Good. So we covered the LPA, which is quite important, and I think people got confused when coming to the LPA. And you mentioned that the LPA should be registered in the office of the public guardian.
Exactly.
Yes. Is there any chance that if we came to see a patient in the A&E and that patient, we suspected that there is some LPA in place and we don't have clear information yet? So is there any chance that we can contact this Office of Public Guardian to know if this patient has been registered with them or if there is any valid LPA in place?
So if the person who's been appointed to have the LPA, if they don't have the paperwork, which is signed and witnessed and it's been registered by the Office of the Public Guardian, and they are claiming that they have it, then I think it's appropriate to talk to our legal team in these situations, because that's a must. This document must be registered with the Office of the Public Guardian.
Public Guardian, yes. Now I want to talk about sometimes we can deviate to use the common law for a specific or certain condition or certain situations in the hospital. So what do you think when we can use the common law?
All right. So basically, we use common law at times when there is immediate emergency and there is no time to use the Mental Capacity Act nor the Mental Health Act. For example, you have someone in the waiting area and that person is immediately trying to kill himself or to harm someone else, and there is no time to assess capacity or anything, then this is where we use common law to protect the person from harming himself or harming others. And it lasts by the end of that emergency.
Right. So once that emergency is finished, we can come back to normal assessment tools.
Yeah.
Brilliant. Now I want to talk about the DOLS, deprivation of liberty and safeguards. So when we can apply DOLS?
Okay, so deprivation of liberty and safeguards, it's applicable in hospitals and or in care homes as well. Okay, and basically this is again a legal document. Okay, and it's only issued for those who needs continuous observation. Okay, and they are not free to leave. So basically, it's applicable even in the emergency department, but we very rarely we might need to do it. Okay, if any, because usually in the emergency department, our aim is to provide emergency short-term management for our patients. So usually we don't use DOLS. However, our patient might present it from outside, from the community, accompanied by that document for DOLS.
Yeah.
Or if someone is admitted in any of the hospital wards and actually they lack mental capacity, then they might have that being done in the ward. So it falls under the Mental Capacity Act. All right? It doesn't have anything to do with the Mental Health Act, but it's more of mental capacity thing.
Okay, good. And I think we I wanted to speak about how to address an agitated patient in the emergency department. I think as we had our conversation, we came across that, how to assess and manage agitated patient in the ED, and we spoke that we need to start with verbal de-escalation initially, and if that's not working, and we found that patient is proposing harm for themselves or for others, we can use the chemical restraint. And this is, we mentioned that it should be at least or least restrictive once the agitation is gone, and we need to stop that. And let's talk about the suicidal patient.
So can I first comment about acute behavioral disturbance?
Yes.
Because this is a really important issue, and frequently we have patients attending or brought to our emergency department with acute behavioral disturbance, and often it causes a lot of distress and confusion to the whole staff and even to other patients in the department. Okay, we should have our own approach, and there is guidelines by the Royal College of Emergency Medicine about how to address and manage those presented with acute behavioral disturbance, previously called delirium. So first of all, I think our intervention will be according to, and the level of restraint, it will be proportionate to the level of risk to themselves and to others. However, we should first try to talk to the patient. As you said, we need to do like verbal de-escalation first, if possible, and practical. And if that's not working, then quickly we can try to assess their own mental capacity. If you remember earlier, the first principle of mental capacity is presumption of capacity. So I'm not going to say this patient is obviously lacking capacity because they are quite agitated and distressed, but rather I'm going to talk to them. I will just I will use all my verbal and non-verbal communication skills, of course making sure everyone is safe. Yeah,
sure.
And try to introduce myself, and that we are here to help. Try to get the patient to private area, okay, as much as possible, and try to talk to them, and that we are here to help, and try to do capacity assessment, mental capacity assessment. If they deem to us that they lack mental capacity, then we should manage them on their best interest. Given that if they lack capacity and now we are going to treat them on their best interest, then we should use the least restrictive option, to restrain them. Because physical restraint is bad. Physical restraint might harm the patient, they might die because of that physical restraint, because there will be a lot of, catecholamine surge in their circulation, and prolonged physical restraint might harm them and might harm others as well. So if we needed to apply restraint, then we might consider using chemical restraint first. And there is a particular guideline for this, which can discuss in another episode.
Yes, I think the ARCM, they put clear guidelines for how to manage the agitated patient or disturbed patient in the ED, what sort of medical treatment which we can use them to restrain them. And I think this is important. And I want to highlight here as well, when we are seeing agitated patient, it's like not to forget to check the glucose level for the patient, because I think it is quite important, and we are facing that several times that patient came agitated and we found that the hypoglycemia is the cause of their agitation.
Yeah, it's just because it's not always mental health problems.
Correct.
And actually most of the time there will be a physical problem going on. They might have taken, some drugs like illicit drugs, Uh, they might have head injury and intracranial bleeding. I remember seeing a patient a long time ago who was quite agitated and acutely disturbed, and it turned to be hypoglycemia with glucose of 1. And once we managed to give some glucose, the patient returned to normal baseline. So yeah, I agree with you. Any medical problem might cause acute behavioral disturbance.
Yeah, and acute behavioral disturbance is quite a very big topic. And I think we can cover this on one podcast, particularly going to address that.
Definitely.
Yeah. So asking about the suicidal patients coming to the ED, what are the tools which we can use to assess or to determine the risk of suicide for those patients, and what category we can use to categorize them as a high risk or low risk, and what we're going to do based on that?
Yeah. I mean, for our patients who presented with suicidal thoughts or suicidal attempts or any type of self-harm, the most important is to treat them and keep their dignity, and we need to manage them with respect. That's the most important, okay? Obviously, they have some issues which might be related to their mental health, okay? But that needs to be addressed. So as soon as possible, they will return back to their normal, physical and mental health and continue their life. So we need to put that in mind, all right? How to assess suicidal risks? So there is a lot of tools to assess the risk of suicide. One of them is the modified sad person score. This is one of the frequently used tools to assess the risk of suicide. And it's quite easy. I think it's important for every emergency medicine practitioner to have understanding of it. Because if the patient is at high risk of suicide, then it might not be safe for them, to leave, okay, before having mental health assessment, because they might pose risk to themselves or to others. So the modified sad person score, if the patient age more than 45, we will give 1 point. If he is or the patient is male, that's 1 point. If they have history of depression, that gives them 2 points. If there is rational thinking loss, which is if they have features of acute psychosis, that gives 2 points. If actually there was organized attempt of suicide leading to this hospital presentation, then that's another 2 points. And if you ask them, if you left the hospital, is there any chance to actually harm or kill yourself? And if they said yes, then this is another 2 points. Social isolation gives 1 point, okay? And if he's like widowed or divorced, that's another point. Using illicit drugs or excess alcohol, that's another point. So it's really important to try to assess the risk of suicide using the modified sad person score or any other scores. And for this particular tool, if the score is like at least 6, then the patient is at high risk of suicide. Even when I talk to the mental health team, if I told them that I have assessed the risk of suicide and they are scoring like at least 6 in the sad person score or the modified sad person score, then even the mental health team, they will consider how serious the condition, and it would make the communication between us and them simple, okay? And even you can convince them to urgently assess the patient. So yeah, it's really important for us to assess the risk of suicide for our patients who presented with self-harm, or if you think they are at high risk to commit suicide if they left the hospital.
That's correct, and I think it is worth to calculate this risk and to determine if the patient is on high risk, yes or no, because the management plan will be completely different if we didn't assess that and the patient is on high risk category and the patient left the department. There is a very proportionate risk that they're going to commit the suicide, particularly if their previous attempt was organized and they are scoring very high. And I just want to stress into one point here that those depressed patients coming to the ED, we need to, as you mentioned, to treat them with dignity and respect, and we need to have an empathy with them, and we need to show the support from our side as doctors. It is not a matter of just doing this assessment and then refer them to the psychiatric care. It's rather to support them, and I think this is also part of the treatment. It is not only for the mental health team or the psychiatric team who can give that support. I think we can do that as well to initiate this part of the treatment. All right. So talking about the suicidal risk assessment, this can just bring us to the mental state examination. I'm just going to highlight the importance of mental state examination. I think we are facing different types of mental health patients coming to the ED frequently, and they are just like maybe mania, depression, or schizophrenia. So various different type of mental health patients, and it is worth to have a mental state examination done. Most of the people think that the mental state examination is dedicated only for mental health team. I think we as doctors, we need to have an idea about the assessment of the mental state examination. This also will give us an idea about what's going on with the patient and how to communicate these findings with the mental health team. What do you think about this point?
I 100% agree with you. So doing or assessing the mental state examination for our patients who presented with mental health problems, that's a cornerstone for the assessment. Doing mental state examination is just like assessing the blood pressure for someone who presents with physical problem to the emergency department. It's just like doing the visual acuity for someone presented with eye problem. So all of the patients who presented with mental health problems, we have to, assess their mental state examination, even to understand what's going on. And also, as you mentioned, it's important to communicate with the mental health team. Regarding the mental state examination, actually we need to assess like 7 points, okay? Appearance, behavior, speech, mood, thought, cognition, and insight. All right? And surprisingly, that will give a clearer idea about the mental health problem the patient is presented with.
Brilliant. So it is quite important, and for us to have an idea about the components, and then I quite advise people to have general information about the components of the mental state examination, how to do it, and it is quite important for us, particularly for us as frontline doctors working in the emergency department. Right. So I want to talk about the initial presentation for patients coming to the hospital with psychotic features. And those people are not labeled as having psychiatric illness in the past, but they came with features indicating underlying psychosis. So what do you think about the initial assessment for those patients? So shall we just refer them directly, or we need to do other things with them before doing an official referral to the mental health team?
I mean, I think it's important to do our assessment first, and the reason simply, not all psychotic features are caused by mental health problems. There is a lot of features of psychosis presented as consequence of physical health issues. Let me give you some examples. Someone, for example, he is hypoglycemic, might present with features of psychosis. That's the previous example we mentioned a few minutes ago. Diabetes sometimes, in general, might affect our cognition. Okay, Addison disease, a lot of infections, sepsis, any sort of sepsis. It's common in sepsis to have, like for example, visual hallucination, sometimes auditory hallucination. So it's really important for any patient presented with features of psychosis to have physical assessment as well, in particular, elderly population. So frequently you might have a patient on your list to be seen, like 60-year-old or 70-year-old, and coming with, visual hallucination or auditory hallucination or any sort of psychotic features. For me, those people, they have physical problem causing that until proven otherwise. I don't think it's appropriate, in particular for the elderly, to be referred directly to the mental health team. I think they should be seen by us first.
Correct. Yeah, so I think the general assessment, as well as you mentioned, there are many diagnoses which can lead to this psychotic behavior. For which of them, Addison, you mentioned, and we need to check the electrolytes for the patient as well, doing proper assessment, do the proper investigations. And sometimes it might be related to brain problem. Sometimes exactly. We might need even to step to do a scan for the patient, scanning the head, to make sure that we are not missing any brain pathology and infection generally. Also meningitis and encephalitis.
Exactly.
All these can lead to disturbed level of consciousness for the patients, and they might present typically just like psychotic patients.
Yeah. I can't tell how many times people presented with meningoencephalitis, and they were initially missed and managed as having acute psychosis because of mental health problems.
Right. And you mentioned hallucination. So what sort of hallucination? We have two types of hallucination. We have auditory and we have visual hallucination. Which one of them goes mostly with psychotic and which one goes with organic?
So basically there is many types of hallucinations. Additional to visual and auditory, people might have tactile hallucination, where they will have like itching everywhere, and they feel something is moving under their skin. So for physical problems, for medical problems, the most common is to have visual hallucination. However, they might have any type of other or any other type of hallucination. And for mental health, problems, if someone is in acute psychosis because of their mental health problem, actually they might have any of these features as well. Auditory, visual, or tactile. Alcohol withdrawal, one of the most common causes of tactile hallucination, but also it might cause visual hallucination as well. So, yeah, we need to consider other possible causes first.
Yes, yeah, that's correct. Yeah, and I think the features, most of them, as you mentioned, it is non-auditory type of hallucination, which is visual. It goes more with rather organic problem. And then if we got a gait disturbances, this is also goes more with organic problem rather than functional psychosis and focal neurological deficit. So all of this depend on your assessment, your history taking, and your proper investigation. Is there any point you want to add it more generally to wrap up this podcast session?
I mean, we've covered most of the points we plan to do. If I'm going to add something, then probably regarding children. So those who are under 16, we can't manage them by Mental Capacity Act. Rather, we need to assess them under the Children Act 1983. Probably we are going to talk about the Gillick competence and Fraser guidelines in one of the future episodes. Is that right?
Yes, definitely we're going to do that. Yeah, I think we managed to talk about everything related to our topic today. And thank you, Mohammed, for sharing with us those nice information. And thank you guys for listening. And hopefully we're going to catch up with you in our next podcast. Please feel free to share this podcast with your friends. And if you have any comments or if you have any specific topics you want us to talk about, please feel free to post that in the comments, and we are going to deal with that as we are progressing through. Thank you. Thank you very much.
Thank you so much. It's my pleasure to participate in recording this episode. And yes, if anyone is having any questions or comments, we are happy to have them and discuss more. And hopefully we'll see you or talk to you in one of the future episodes soon.
Thank you.